Okay, everyone, please continue to share in the chat where you're calling in from, but I would love to get us started. My name is Naya Harper. I'm the Senior Research Project Manager with Recover on the Community Engagement Team, and I'm happy to welcome you to our study site spotlight this evening on engagement best practices. So right now, I'm taking us through the opening remarks, Learning Hub guidelines, tips for Zoom, the agenda, of course, and I'm going to be in a little bit introducing our speakers. We do have next the presenters, which will be Jackie Lindsay from BCRC presenting. We will have Jerry A. Krishnan from ILLInet presenting. We will also have Kathy Kulik from Bright Star Community Outreach presenting as well. And then Alejandra Abanez from Illinois Unidos presenting as well. And then we're going to have our closing remarks. And don't worry, in between each of those presentations, you will have an opportunity to ask questions. So it won't be all the way at the end. So you have to retain all the information. Remember what you thought. It's going to happen live during each presentation. Now, I would love to talk us through who our speakers are and welcome them to the space as well. They're amazing presenters. First, we have Jackie Lindsay, the president of Innovation by Design. So Jackie Lindsay is the founder of Innovation by Design, an organizational development consulting firm that specializes in strategy, innovation, and leadership development. She brings over 30 years of experience working with organizations, communities, and leaders committed to social and systems change. Ms. Lindsay's work focuses increasingly on building, learning, and leadership communities for social change by supporting diverse groups of people to come together across boundaries, organizations, cultures, communities, and generations to examine issues that affect their common future and to provide the vision and leadership necessary for breaking new ground. We would love to welcome you, Ms. Jackie Lindsay. Thank you so much for being here. Next, I'm going to welcome Jerry A. Krishnan. He is the principal investigator for the ILLInet recovery study. He's a physician scientist with expertise in the care of patients with asthma, chronic obstructive pulmonary disease, and other complex obstructive lung disorders. Dr. Krishnan is an expert in care delivery science and an investigator in National Institutes of Health, the NIH, as you know, and Patient-Centered Outcomes Research Institute, funded by Research Networks. So thank you, Dr. Jerry Krishnan, for being with us. We're looking forward to continuing the conversation with you as well. Next, we have Kathy Kulik, who is the Director of Community Affairs and provides leadership in the Health Department at Bright Star Community Outreach. Kathy's leadership has led to successful implementation and growth of the organization's newly funded programs. Congratulations on the newly funded programs, and an increase in collaboration with other community-based organizations, schools, and hospitals. So thank you, Kathy Kulik, for being with us today. I'm looking forward to asking you a couple of questions during your presentation. And finally, last but not least, we have Alejandra L. Ibanez, who is the Executive Director of Illinois Unidos. This is a statewide coalition of Latino health professionals, community-based organizations, and elected officials committed to the equitable COVID-19 response and recovery for the state's Latinx population. She has spent her entire career creating and facilitating relationships, programs, initiatives, and institutional partnerships that elevate the voice, power, and agency of historically marginalized communities of color, including her Latinx community. So thank you so much, Alejandra. And we look forward to continuing the conversation with you as well. So that welcomes us to the NIH Recover Site Spotlight for engagement best practices. And this is going to be a roundtable discussion. And to welcome Jackie to the table.
Thank you, Naya. So this is our team of PIs, and you notice that we are a multi-engagement strategy, multi-site engagement strategy. We started out with 6 and now have a 7th site joining our effort. And our effort is the Boston COVID Recovery Cohort, otherwise known as BCRC. Supporting the planning to date is the team that you see below. It's led by our 2 lead PIs, Dr. Bruce Levy and Dr. Ingrid Bassett. And Dr. Ingrid Bassett is on this call, so I'm glad that she can be here and contribute her insights. And then what you'll see underneath are people representing each of the 7 participating sites. The National Community Engagement Group really challenged us with addressing 3 questions. And the first is strategies we've implemented that have delivered results we've sought. The key one that we want to put on the table is our approach. We've established a community partnership table as a collaborative governance structure to guide the work of the BCRC. One of the things that we're doing in this work and at this table, it's a table that really brings together community partners with the health system partners, with equity partners. And what we see in this table is that we have 3 levels of goals for our work. The paradigm shift in this work is that in addition to achieving the NIH Recover Study goals, equally important in our work is centering community leadership and health equity in our approach. And for us, that means that beyond achieving the Recover Study goals, we're also focused on equitable clinical care and patient support for study participants, and addressing systemic racism by getting the buy-in and support of hospital leadership to learn from community and each other how to advance health equity to improve our diverse communities' health. You probably could be showing me slides like this for each of your communities. We believe this paradigm shift is needed in Greater Boston because there is a disproportionate impact by race, ethnicity, and geography on who has been hardest hit by COVID, and also by the underlying systemic factors across issues, otherwise known as social determinants of health, that really make these the most vulnerable populations and communities susceptible to COVID and long COVID. We have shared broad goals for this partnership. I've outlined some of them earlier: accomplish goals related to long COVID, address systemic racism by centering health equity throughout this project, use what we learn from the study to accomplish additional goals to improve the health and healthcare of our community, create a collaborative leadership structure, the community partnership table to guide the project, define indicators of success and key strategies to achieve project goals, and share what we learn with others. As a community partnership table, we are co-designing, co-developing, and collaboratively governing the project. We're serving as a structure to support bi-directional communication and collaboration. We're informing our work by learning from Boston's diverse communities what they need when they come for long COVID care. And we're building shared understanding, engagement, trust, and that's a big one, and relationships among the partners to collaboratively guide, learn from, and lead the work to accomplish its goals. Early successes from the table, and we're just getting started. We've held community convenings and also listening sessions to learn from community stakeholders to establish and set goals for the table and organize its work. We've received recommendations for diversifying outreach for completing recruitment. Community feedback, important values to uphold this work: intentionality, uplifting the underserved, focus on social determinants of health, commitment to and respect for community, improving health in measurable ways, both short and long term, inclusive community-led partnership, commitment to building authentic relationships, being a role model to equitable community leadership, focus on dismantling systemic racism, especially within our care institutions, and the ability to hold systems accountable and get institutional buy-in from senior leaders. These are some numbers that let you know the goals that we've set for the Recover study and enrollment. And you can see the total is 909. We're at 603 to date. And our understanding is our window closes in December for us to reach our goals. This zeroes in on enrollment by Hispanic ethnicity, and you can see what those numbers are in both cases overall, and with enrollment by Hispanic ethnicity, we are 2/3 of our way through overall, but we've got some serious gaps to close by different racial groups. Basic challenges to date: getting the word out, the length of the study visits, the languages available in which to reach and recruit our very diverse population. The scheduling appointments taking place during working hours doesn't work for a lot of people who don't have time off. Continued challenges include transportation to get people to their visits, difficulty in enrolling patients with disabilities, the inability to answer many of patients' questions so early in the study, and special populations to involve, like those who are unhoused, and we also have privacy concerns, digital access. We were asked what the National Program and Community Engagement Team can do to support our efforts. And it's no surprise, the highest priority issues for our table are what you see here. I think the reason you see the particular priority reset from a place of true partnership, this is a challenge for us locally, and it's also a challenge for us between local and national. Specifically, if you look at the bottom, you can see what the challenges for us were presented by the fact that the study scientific processes were far ahead of the community engagement processes. Otherwise, they were set up first. They hit the deck running, and as many of our community members who are coming to the table are saying is, it feels like the train has already left the station and we weren't on it. They're clear that this needs to change, and that the work of community, of our hospital partners and of our equity partners all needs to be aligned. These are, again, zeroing in on forming a true community-based, community-led research process and following recover methods and study. And that is within our project locally, but also between our project and nationally, that creates alignment. Okay, so I want to wrap up my presentation by saying this. We're in the early stages of setting this up. The greatest tension in the project locally and between our local project and nationally is making sure that community engagement, and by that in our project, we mean community leadership, is at the decision-making table. And it's not an afterthought. It's not community members as advisors, but community members along with the scientists, along with the equity partners, are leaders in driving the project. One of the things, the biggest challenges we're facing to date is the challenge of NIH setting goals, for example, for the time by which the window will close around recruitment and the time it takes at the community level to build the trust and the relationships to make sure that we are diversifying our study pool that reflects the diversity of our community. Otherwise, we're going into a project, a novel disease that runs the risk, if we don't diversify the study pool sufficiently, of basically developing all of its standards based on a white and principally male population and not the diversity of Greater Boston. So we need the real support of national to align with the deep community engagement that we're trying to support at the local level. And now I'll open it up for questions.
I do want to pose one question, and being cognizant of time, but I would love to hear from you, Jackie, a little bit more about what are some of the tangible steps other studies can take to contribute to the paradigm shift you were talking about. So I think you were getting at that a little bit in your closing remarks. So I'd love for you to be able to expound on that a little bit.
I can't speak for other sites because everything in our work locally is being driven by our shared values. So we all embrace the goals that NIH set for the study, meaning we believe this is a novel disease. It's bigger than all of us. It continues to evolve. We need to put all of our heads together to figure out really how to understand this, how it's impacting our communities, how to address it. We agree with all of those, but we find the practices that have been set up, it's basically been driven by the researchers. And yet, to achieve these goals, we believe we need to have a table that's set with community at the table as genuine, authentic partners in the decision-making with the researchers and with the providers of long COVID clinical care. And so what we don't find in place, and I think this would affect all communities across the country who are participating in this, if there are other communities who are trying to make their work authentically involve community leaders and community members as partners, they're going to find that they're running up against a top-down command and control paradigm that comes from NIH. It's just straight up. And we think that NIH's science goals are important, but we actually believe that it's critically important to center community leadership. It's critically important to advance health equity in order to achieve the science goals. If you achieve the science goals without centering community leadership and without advancing health equity, we believe that the science goals are going to have limited impact. However, if you do center community leadership and you do advance health equity as you're achieving the science goals, we think that the project will have much greater impact. So that would be the invitation to the other communities. I think communities need to have a stronger voice within the whole Recover project. We have structures, but structures are not the same thing as voice and equal in decision-making to the scientists at the national level. So we feel the misalignment and we welcome alignment, and we will push for it.
Thank you so much for that. I appreciate you sharing those limitations on impact as well and how to combat them. I want to make sure I'm not missing any raised hands. I do see Kathy's hand is raised, so I would love to invite you in to ask a question.
Hi, Jackie. You know, I'm such a great fan of yours and the work that you do. My question is, what experience have you had signing up or working with, or when it comes to the Black community or the Black population in Boston with the study?
With this study?
Mm-hmm.
Okay. Interesting. Okay. Precursor. Prior to working with this study, I have been a part of, and still am, a part of an organization that was created under COVID called the Black Boston COVID-19 Coalition. And we created it because we saw the Black community was being the hardest hit of all and was not being attended to either by city or state leadership. So Black people in the community came together to understand what was going on in our community, collect data about it, bring that to citywide and statewide attention to ensure resources, including getting a major mass vaccination set up in our community, which didn't exist. It was being set up in white communities all over the state, but not in the Black community. I'm sharing that to say, and what we did from that, we did a study with the Black community. We saw all the research that had been done was very deficit focused, and we decided to go to our community that was being so hard hit, but still rallying, to find out from them what supports their health, their resilience, their well-being, and their hope. And that was a community very deeply impacted by COVID. And they told us, and that we collected that information to make it available to all of the healthcare systems in the city to begin to do this reset where they need to be learning from the community what their experiences are, including with those health centers, with the health systems, what recommendations the community has for improvement. So I feel that through the work of the Black Boston COVID-19 Coalition, which I'm still a part of, and now moving into this phase of the pandemic's focus on long COVID, that all of the work and all of the connections to that community are now being brought into the long COVID work. Does that answer your question?
It does. Thank you, Jackie.
Yeah, my pleasure.
Thank you so much for presenting, Jackie. We appreciate the questions that came in, and we would love to hear more from you. So I'm sure we're going to have folks here keep up with you as we move along. And I would love to welcome Jerry Krishnan into the space to begin presenting and sharing with us as well.
Great. Hi, Naya. It's Jerry Krishnan. Can you hear me okay?
Yes, we can.
Wonderful. Thank you so much. I want to thank your group, along with everyone who's attending today, to give a few minutes for the Illinois Research Network to talk to you about how we've been structuring our approach to ensuring that the communities are represented appropriately in the Recover program. I'm the overall principal investigator for the Illinois Research Network, which we call ILLInet. I'll have my colleague Kathy and Alejandra also speak to you. And as with anything that's important and is difficult to do, we have a pretty big team, and Angela Tobin, Ruby Camacho, and a number of others also are part of this project. They'll be participating in discussions if there are questions for them. Next slide, please. So this is the Illinois Research Network, so ILLInet's approach, along with what we just heard from Boston, which we wholeheartedly agree with their approach. We thought about the study through the lens of the people who are most affected by COVID from the very beginning. Our entire research application that we submitted to NIH was built on the notion that we need to begin with the people most affected by this condition and work with these communities to create a multi-stakeholder approach to actually developing a plan for how do we make sure that the Recover study is meaningful to all stakeholder parties. So what we wrote in our application, which we continue to practice, is this concept of a really proactive engagement approach with our community partners, two of whom are represented today on our session, to leverage our existing relationships. And I want to underline that we work with a number of organizations throughout the Chicagoland area and in Peoria, and we went to these organizations from the beginning to help us form essentially a trusted community partnership in order to ensure that the people that we engage, the people that we invite to join the study are as diverse as possible to ensure that the science is relevant to as many people as possible. Our partnership model, which I think we've heard already from the Boston team, evolves at the speed of trust. This is a trust model, and not only a trust of obviously us as researchers in Chicago, but also trust about what the science is all about and what is it that we're going to learn and how relevant is it to us. Our North Star is that there needs to be value in both directions. This can't be a situation where the study goes on to enroll people and extract information, and then at some point later, perhaps in a trickle-down approach, some value comes back to communities. We had to think from the very beginning, how do we make sure that this process provides reciprocal value from the beginning in whatever way is possible? And finally, we view these building blocks as critical, as laying the foundation for other work that are yet to happen. We know that obviously the current Recover study is about understanding why some people develop long COVID and why others don't. What are the different patterns of long COVID? But all of that is to then identify and test and implement strategies to help people who have long COVID. And in order to involve individuals that are as diverse as possible in these subsequent clinical trials, this is laying the foundation for that entire approach. On the right-hand side of the slide, what you can see is that, as many of you may know, if you visited Chicago or if you read about us, is that Chicago is one of the most segregated cities in the US. Depending on who you are, you might pick certain neighborhoods to live in. And what I'm showing you on the map here, this is from 2020, so it's about a year old, or about 2 years old. is that these are the individuals, according to race, who have developed COVID. And you can see here that there's really a pretty impressive separation between the green dots and the orange dots, and a few individuals are the blue dots. And so that represents the African-American community, the Black community, the brown community, Latinx, as well as individuals who are white. We do have some smattering of red that you can barely see, but it's in the top part of the figure. So as we thought about recruitment and as we thought about engagement, we had to make sure that we work with individuals who have authenticity in those communities. We can't be recruiting or inviting people to join from our health system. We have to work with individuals who have legitimacy in those various neighborhoods. So this is a lot of information here, but I want to summarize for you what I think I heard from our previous speaker in Boston as well, which is overall, the Illinois Research Network is meeting our enrollment target. We have a little over 600 people enrolled. I'm pretty confident we'll make our target enrollment of 900 or so by the end of this project period. So we're on track. However, what is perhaps less clear to individuals who are not running these research hubs is that we very intentionally identified 5 enrollment sites. One of them is the sort of the typical health system. That's the one that I work at UI Health. But we also identified a partner that is a federally qualified healthcare system. And many of you know that these FQHCs are in neighborhoods that are often disadvantaged for a number of reasons. So we wanted to directly work with the FQHCs in order to have reach into those different communities. We also are going to hear from representatives of BrightStar and Unidos about the constituencies that they have trusted relationships with, because we wanted to go beyond healthcare systems. We wanted to have community-based enrollment, community-based samples, and frankly, community ownership of this project. So they felt that their voice was being represented and that we would learn through their activities. So BrightStar, Unidos are actual enrolling sites, which is a little unusual in the entire Recover program. And then finally, we partner with the Public Health Department in Peoria, which is a city a little south of Chicago. So their Public Health Department actually found an enormous interest in the Recover program because they were feeling the public health burden of long COVID, and they wanted to participate in this study. So they're also participating. So this model of 5 enrollment sites that are a little atypical, involving community-based organizations as actual enrolling sites and a public health department actually as an enrolling site, was an innovative approach that we thought was a demonstration of a proactive community-based approach that allows us to essentially leverage the strengths of each of our partners in terms of the types of populations that they can enroll, and therefore also the demographic characteristics of people that they enroll, as well as the lived experience of those individuals. You'll see on here that there's quite a bit of variation about when these various enrolling sites were activated. That's in part because we had proposed a slightly different model than I think had been traditional, and took us some time for us to get everyone to agree to this sort of proactive community-based approach. I'm now going to hand over the rest of the session to my colleagues. And if it's okay, I'm going to save questions till the very end because we have one wrap-up slide that brings all of this together. So I'm going to have our representative from BrightStar then take over from here.
Greetings, everyone, and thank you for giving me a few moments to kind of just pinpoint things that we're doing and who we are and what's working best. So BrightStar Community Outreach is the name of our nonprofit organization. We are located on the south side of Chicago in the community of Greater Bronzeville, and Pastor Chris Harris is the CEO. If you don't know him, please Google him. You'll be watching YouTube for hours. All of our efforts and programs are structured around 2 main focuses, trauma and training and community conversation and collaboration. We are the community mobilizer for the residents, for other community-based organizations, faith-based organizations, schools, hospital. If you want to reach the community, we are who you come to on the south side of Chicago. BSCO looks at the entire picture of services needed to be able to provide a holistic approach. So instead of just a single pronged approach, we take a holistic approach. With over 79 partners, we're able to provide an ecosystem of care. We think of ourselves as the convener and not the competitor. If we can't do it, we know someone that can. Partnering with the university gave us an opportunity to begin the process of building trust back with our community, which is predominantly Black, and medical research. You see on the side there, Pastor Chris Harris has a quote that says, "The university said, this is what we want to do. We want to let the community lead the process, educate the people." And they said, we're coming to the table not only as educators, but we want to be educated. That is what is different. That's why we jumped in. So what is working? So since May of 2022, we have had 208 referrers, which is a huge success in our eyes. 208 residents that have said that they wanted to participate in the study. We have found that going to the residents versus having the residents come to us is what works best for enrolling them. So looking at what events are happening in Chicago and sending our community health working team out to those events to explain what the study is and get people to sign up versus holding events where we're crossing our fingers and hoping that people come just to sign up. We lead recruitment with conversations, ensuring that residents know that this is an opportunity not only for them to share in the responsibility of bringing resources for their neighbors and their family when it comes to long COVID, but that they're also able to earn an additional $800 to their household income, which where in our community, the medium income household is anywhere from $22,000 to $25,000 a year. So $800 goes a long way. We also continue to build new partnerships, which allows us to have access to their trusted client base. We have our trusted clients who know us, who will say, absolutely, Bright Star says it's gold, so I'm in with it. But reaching people in Inglewood that we don't know, that, know Teamwork Inglewood, and can vouch for us for the study. Lastly, we've been sure to keep the community's feelings in mind. So for example, we had an in-depth conversation with the university where we said, hey, the people that are coming to the community to explain the study, they have to reflect the community. Otherwise, the community is not going to trust the study. And of course, they've been receptive of that. So challenges that we've had and how we plan to move forward. Residents aren't answering the phone, right? So Recover was originally calling from a toll-free number. In the Black community, in any community, if you see a toll-free number, you're probably not going to answer the telephone. So as soon as we realized that was a huge barrier, we started working right away to fix that. How do we move forward? So, allowing our residents to say, hey, can you store this number in your phone under the Recover study? So when they call, it's them calling. I also know that we've been working to get the caller ID number changed so that it doesn't say toll free when the call comes anymore. So that when that call comes, the residents answer the phone call. The next one is the lack of trust in research. And I really, really want to point this one out because it's extremely important in our community. From the 40-year-long 1932 Tuskegee syphilis study, which is widely recognized as a reason of mistrust between the Black community and medical research, to as recent as 1990, where there were studies being conducted that were unethical to the Black community, that were incentivized by monetary, that were encouraged by monetary incentives to sign up. The Black community doesn't trust medical research. So it's going to take some time for us to build that trust, for them to say, okay, I'll participate. Let me sign myself up. Let me sign my husband up. So we figured that doing testimonials from other residents that have participated in the study and have gone through certain steps in the study to say, hey, this is okay. This went smoothly. I enjoyed it. They have everything figured out, and broadcasting that so that it just continues to build that trust. And the last one is the 4-year commitment. That is a long commitment, right? A lot of our residents aren't even thinking past 2 months from now. So for them to commit to 4 years is a long time for them. So how do we rephrase that, right? How do we rephrase that to say maybe, 4 phases that are a year each? It's almost like saying, I can give you 1,000 pennies or I can give you $100, right? How can we say that won't resonate with them as, man, I don't know if I can live up to my end of the bargain when I sign up for this. So no, I don't want to sign up for it. I'm okay. And that is it. I hope I didn't go over my time, but I am looking forward to questions.
Great. Alejandra, I think you'll go next, and then we'll take questions at the end. Thanks, Kathy.
Thanks, Kathy. Thanks, team. Hi, good evening. Buenas noches. My name is Alejandra Ibañez. I am the Executive Director of Illinois Unidos. So happy to be with you all today. And good to see some former colleagues and friends. I see you, Felicia. Illinois Unidos is a statewide consortium of over 100 Latino elected and appointed officials, doctors, FQHCs, public health, and community leaders, including community health workers who we hold to high esteem in our organization. Illinois Unidos was formed in response to the COVID-19 pandemic during the spring of 2022. We came together as one united voice to stop the surge of COVID-19 in our state's Latinx community by providing bilingual, bicultural information, communications, and collaborations with local, regional, and state public health departments and community organizations and leaders. Over the past 2.5 years, we have also advocated for the equitable response and recovery from COVID-19 by supporting the passage of legislation that protected essential workers against retaliation for going and just to get vaccinated. We've also have worked at the state level to ensure extended protections for workers and data transparency on COVID-19 outbreaks in warehouses and in the manufacturing sector. We've done that and so much more because being able to provide information while critical served as the first step to extending our advocacy to the next level. And as you'll see on this first slide, one of our co-founders who's on the phone call with us, Dr. Marina del Rios, was the first person to receive the COVID-19 vaccine in the state of Illinois. So proud to have some incredible, highly committed folks make Illinois Unidos. They also form folks who are on this slide, including the Mexican Consulate, the Latino Policy Forum, and so many others. So what's working? Well, we were slightly delayed in waiting for some of our outreach materials to be translated. We have referred over 300 participants since May of this year. We've been able to elevate our own bilingual, bicultural broadcast programming on Spanish language TV, Univision and Telemundo, as well as our very own Spanish language radio that is on live every Saturday morning from 9 to 11 o'clock. Those are opportunities that we have built and created and fostered over the last 2 years to make sure that good science and good information on what COVID-19 is and isn't is provided to a large swath of our community across the state of Illinois. We've also leaned into a number of our organizational partners and our own infrastructure. While we are only a 2.5-year-old project, we have been able to build a membership of over 150 individuals and organizations. We have a workplace committee, a community health worker committee, an education committee, and a health and policy committee that has really allowed us to do cross-sectional work. Because as you all know, COVID-19 has impacted our health, but it's also impacted our community through lack of housing, loss of housing, jobs, education attainment, etc. And we have really come together across those issues and sectors to educate, mobilize, advocate, and be able to pass necessary policy solutions to the devastation that COVID has brought our community. So despite what we think are some pretty strong referral numbers in a short amount of time, we've experienced some barriers, historic challenges, many of the same challenges that you heard from Kathy and Jackie that are no different in Chicago. So to the first point, which is a point that we share with our African-American family, is the lack of trust in research. This also is very true in the Latino community. What are you going to do to me? What are you going to do with my information? These are questions that come up all the time, right? And so one way that we're combating these real challenges is about providing testimonials by those who are already participating. And I will share with you, I myself am a participant. Many of our partners, our community health workers, they too are participants. Some of us really wanted to make sure, while we have complete trust in the project, we wanted to experience it for ourselves so that we could articulate directly to our partners and members of ILLInet about what's working, what's not working, and be able to speak to our own community members who are recruiting. And so we have done this and are actually talking about doing this both in our digital and social media, so that we can share with folks how this is a trusted partnership, how this is a trusted program and project, and that it's a safe and necessary exercise so that our community could learn, and the community and NIH can learn about how COVID has impacted our specific Latinx community. I wanted to also dig a little bit deeper into this lack of trust, because it also is tied not just to Latinos, but I would say immigrants themselves and their own fears about their status, their immigration status. It speaks to the safety and security of their identity. Who's going to know about me and my immigration status? Will they know where I live? Are they going to come and visit me? Should I be concerned about sharing my own identity and status? It also speaks to the unknown. Similar to our family in the African-American community, Latinos have been historically shut out of access to healthcare. Many of our community members do not have a medical home. And so being able to navigate a study like this is a new experience for folks. And so what we've learned is it's an issue of accessibility. It's an accessibility of language, accessibility of literacy with all those surveys. It can also be navigation and accessibility of navigating healthcare. I'm going to go to a clinic for the first time. How do I access it? How do I go? What are the questions that I ask, right? And so that really has required Illinois Unidos to step it up. And we've leveraged our own call center to make sure that our community members are getting the support to be able to navigate, feel comfort and safety in participating in this study. And then I'll say lastly, finding and enrolling acute infected individuals within the acute window has been tough. We've got 3 weeks to be able to identify folks who have more recently been gotten COVID. And so that means that we have to move fast and that connections need to be made faster. And so again, something that we are leveraging is our relationships with community health workers who are already in community, who are already seen as trusted partners in community, but we are now leveraging our own call center so that we can hand off our referrals directly to UIC, so that we could be lending that hand, so they know that we have built their trust, and now we're going to hand them off so they can then talk about the project and provide their consent by being handed off again by folks that have built the time and trust to recruit them. So again, I'm the lucky team member who also gets to share with you some of the things that we could use from the community to help us reduce some of the barriers for CBOs to serve as enrollment sites. We may not be the health experts, but we have built long-standing trusting relationships in community. How do we work in partnership? Let's simplify the study protocols so that there isn't so much participant burden in understanding and navigating. Let's help distill the clinical information so it's more accessible and understandable. How about those return results? What are we learning? Are we sitting down with folks and explaining what these results are? Again, let's remember that many of our community members of color do not have access and have not been able to navigate the healthcare system. So they're going to have a lot of questions and fears, and we need you all to meet them where they're at. And then, of course, we want to make sure that we're linking the research to the actual provision of services back to the community. Again, just to reiterate, a number of our community folks who we are recruiting do not have a medical home, and we are bringing them into a study and an experience that is a first in many ways. So those are some of our top ideas that we wanted to share with you, and we wanted to open it up for Q&A. Thank you so much.
Yes, thank you so much, Jerry, Kathy, Alejandro, for your presentation. That was extremely informative. And as you mentioned, Alejandro, we would love to open the floor for Q&A. I would love to invite all of you to the chat as well. If you haven't, if you have any questions there, we do have one so far. But if you're not comfortable coming off of mute, I would really like for you to be able to feel comfortable to ask questions in the chat. And I do want to name that we are close on time. It's coming up on 5 o'clock. So if you have other commitments, as mentioned, or if you're a little bit tapped out and 5 o'clock was your time, we are perfectly comfortable with you potentially leaving, and you don't want to make sure that you don't feel obligated to stay on. But we would like to open the floor for questions, and please, again, use the raise your hand feature. And I'm going to start with a question from Angela Linford in the chat around testimonials. Her question is, are the testimonials anonymous? Some studies don't allow participants to publicly say that they are a participant. Oh, Alejandro, you're on mute.
Absolutely, they are. We provide first names, and that is all.
Thank you so much. Thanks for the clarity. And I see that we have a hand up, but I'm not getting a name on the line.
It's Nora Singer. I'm one of the co-principal investigators of the Case Western site in Cleveland. And I'm at Metro Health, which is the safety net hospital. So I really have two questions about how to communicate back with the community where I haven't been successful. So last November, the conversation started when we knew Recover was coming at a church service that many of the community members attended. And I heard this again about a week ago, that we're not providing funding and really funding for care or social services that the community needs. We're only asking for participation in research. And the thing I heard last week on the listening calls, were that we're also not talking about things that the African American community is most concerned about, or that Recover isn't: worsening of diabetes, downstream effects of having had blood clots and things like that. And I'm wondering how you'd have that conversation back. What's the best response in terms of the community to try and help bridge those waters?
So I'll go and I want to speak to the second part of your question. It's a pleasure to meet you, by the way. Bronzeville is 100% Black. If we received feedback from our community that's where they had concern that we weren't addressing other things that might be concerns to them, the way we would go about doing it is we would bring the community into our space and have those conversations with them. We're big on doing things with the community and not to the community, and having them guide us. So that's something that we would be happy to get out of, information that we would be happy to get out of and move forward with from the long COVID study. So if, diabetes, if our residents are saying, hey, we want to talk about diabetes, great. So we'll put a plan together to have residents physically come in. We'll reach out to the hospitals that we're in partnership with and have those experts come in and have those conversations with the residents, and then put a plan together of how we have those hospitals bring the resources to the community that could possibly help with that. So I hope that gave you some type of direction on
Yes,
that.
thank you.
And if I could share for Illinois Unidos, I think what's really been critical for us is our relationship and our growing investment in community health workers. We've been able to raise a significant amount of dollars that we have reinvested back in community health workers. Our promotoras, as we call them in Spanish. We've been able to provide a space to extend community health worker network outside of Cook County, now into Lake, into Page County. And so it has been the promotoras who really have helped us really recruit for Recover. And they have a regular meeting on a monthly basis. And actually, part of their role is to keep the learning going. They actually help inform all the infographics and health education documentation and materials that we develop. And so they actually recently participated in our second needs assessment. And so part of their engagement in Recover is helping us also be able to pool and collect the concerns and the issues around health equity that come up. And then we respond in kind in our monthly meetings and bring in speakers, provide trainings so that then we can help extend their learning and their expertise on issues of health equity. And so we've had sessions on diabetes. We've talked about issues of cancer. We've actually been able to dig deep into issues of mental health. That is a highly stigmatized issue in the Latino community. And so we actually are now investing in providing mental health first aid, because it's been an issue that continues to come up. And so we've built in a loop with our own community health workers, where they bring back what the community is saying, what their concerns are, what are the issues being raised, and then we are able to then invest in kind in their training and information.
Yes, thank you both for your responses. I would love to know if there are any other questions that anyone might want to pose. If not, I do have, Brittany. Hi, Brittany Taylor. Would love to have you join in the conversation.
Hi there. Thank you all for this great presentation. Alejandra, I think I'm saying your name correctly. You mentioned mental health first aid, and so we provide that also through the Morehouse School of Medicine's Prevention Research Center for free to the community. And then we actually had a local police department ask that we train some of their workforce on it in response to the lack of training in that area. So I'm just wondering, is it provided at no cost to the community, or how do you all provide that to the community?
Sure. We've been able to raise sufficient dollars to be able to pay for the training ourselves. So we are paying for the time for the facilitator. Mm-hmm. And so we provide scholarship to all our promotoras to be able to participate. So it's at no cost. The sessions themselves do have cost. And we also have a workplace committee. So we want to make sure that we are honoring people's time and labor. But yes, so they're provided at no cost to our promotoras who are part of the network. And we have over 20 organizations throughout Cook County, Lake County, and DuPage County, which are part of the Chicago, not the only part, but large part of the Chicago metro region, who get to participate and access those trainings at no cost to them.
Awesome. Thank you.
That is amazing. I really appreciate hearing that the mental health first aid is free between the both of you. That's extremely exciting. Do we have any other questions from our audience? If not, I know it is 6:04. I do have one more question I'd love to pose, and I'll keep it at one question, but I do want to name and thank everyone for staying over so far. But again, want to make sure no one feels obligated to remain. But one of the last questions I'd love to hear from you all and Jackie included, is around the component of trust, which seemed like a serious theme amongst all of you. And we heard what you've been doing to combat the barriers of trust, but have you found that there are, or have you identified any approaches that were trust busters when engaging the communities that you work with? So anything that actually caused a chasm in that trusting relationship that you might have with your communities?
I mean, I was going to share real quickly, obviously having humility, right? I think this is something that, many of us are learning about, making sure that we're coming with humility to listen and learn first versus coming with judgment. Why aren't you vaccinated? What's you right? And this happened very early on, I think, in the pandemic, that folks maybe who had concerns about getting vaccinated, there was a lot of judgment, and that only turned our community away. Clearly, it was a concern. We are all hoping for herd immunity. That never happened, but we really, and I must say, as a Latina immigrant who myself have been going through my own healing, right? The healing that we as people of color living and surviving in this country have to go through. We have to have grace with folks and not judgment, and having that humility, especially in the health and medical space, is absolutely necessary. If you make assumptions or make comments about people's fears and decisions, that is a trust buster. And you can't go back on that. Once you've lost people's trust, it's almost impossible to go back.
That was a beautiful answer, and I resonated with it extremely. It sounds like a lot of people resonated as well. I saw a lot of nods, and there was, resonance as well in the chat from Felicia. So thank you. I think that is a really wonderful way to close this conversation. And I do want to elevate a extremely amazing comment that was actually shared in the chat by Belinda, and I'm grateful that you were able to share your experience. But I do want to highlight it here in this conversation, where Belinda thanked us for having this conversation and shared that to those in the audience, I am African American. I do not work in the healthcare industry. However, I really enjoy my time working with doctors around the country that support recover. As a COVID pneumonia long hauler and POTS survivor, it's nice to have doctors listen to my experience as opposed to fighting for care when I was originally diagnosed. And so I think that is an amazing comment, and wanted to ensure that it was really elevated so that you all continue to feel encouraged and empowered and motivated to do the work that you're doing, because providing this language, this information, and all these resources that have been shared in the conversation and in the chat as well, are really critical to ensuring that our communities are able to push forward, of course, through adversity, but also continue advocating not only for themselves, but fellow people in their community. So Belinda, that was a really great note, and I'm glad that you shared. And thank you, Felicia, for thanking the presenters as well. So I do want to wrap us up here, and thank you all for coming to this presentation and understanding some of the best practices for studies in the study spotlight for community engagement around Recover. We would love for you, of course, Jackie, yes.
I really want to thank the National Community Engagement Group and all of the others who supported this. I want to say something. We're in the early stages of this work. There's so much we don't know yet. One of the things that's so important is that we keep learning, and that as we learn, we respond to what we're learning. I hear this in our communities all the time. When Alejandra and others were describing, and Kathy, the work that they're doing and the information that they're collecting, it's wonderful. It's also very important that all of our institutions, our leaders, our systems respond to what we're learning from communities that they actually need. And what I want to say to all of us, we've been naming some of the barriers from NIH that were imposed on the project. You can just say it's just how they set it up. But as you truly get the community involved, it's very important that NIH listen to and learn from what we're sharing is important to our community. So we don't have to proceed as if just because something was set at a particular point in time, that is the only way that we can do it. If this project is worth anything and learning from all of us in our communities, it is if there's a better way to get it done that actually enhances the goals of the project, let's all, including NIH itself and all of our institutions locally, let's be open to what we're learning from our communities. They actually need, they want, what support they need to participate. All of that is important. So the learning aspect and all of us being open to what we're learning, I just want to say is hugely important.
Thank you so much, Jackie. I really appreciate you naming that. And again, there was a lot of resonance in the chat as well. Excuse me. I want to make sure that we're able to close you all out real well and not shove you off, but welcome you back in different ways. And so if you have any additional questions, you are able to check out more information on recovercovid.org. You can also email us at recover_csc@nyulangone.org. And we also would love to hear some feedback. Always great to have a culture feedback, and you can follow up with us on a survey that is linked in the chat. So if you check the chat right now, there should be a survey directly linked from Carlos, and we would love for you to be able to fill that out. This helps us understand how to better perform with our learning hubs and what information that you all want to continue to see. So what do we keep, what do we stop, and what do we start doing? And finally, we would love to invite you to our next Learning Hub. It is going to be centered around strategies for growth through faith-based initiatives. And so how do we go from not just engagement but also to collaboration with faith-based organizations? And so it's going to be September 29th at 5 p.m. Eastern Standard Time, and it's going to be moderated by Reverend Tony Minor. And we have three amazing panelists who are Heather Elizabeth Brown, Iman Suleiman Hani, and Reverend Max Rodas. They all have different backgrounds that they're going to be bringing, centering long COVID and COVID-19 and faith-based work. And so we would love to share this with you, have you register, which is also linked in the chat as well. And we'll be following up and sharing that information for you to be able to register. And we look forward to you having more valuable input just like you had here.